We do have one more presentation coming up, and that is from Mara Aspinall, who's going to be joining us to share about transforming healthcare, the power and potential of testing.
Hello, my name is Mara Aspinall, and I'm very pleased to be here to present the power and potential of diagnostics and how diagnostics and testing is indeed transforming healthcare. I'm a partner at Illumina Ventures and editor of Sensitive and Specific, the testing newsletter. Let me first share with you my disclosures and the additional board of director positions, as you can see on the slide here. So with that, today I'm going to talk about 5 different topics. I'm going to start with the fundamentals of testing, talk about the history of testing, particularly home testing, and then a fundamental shift in healthcare. What is the role of alternative samples, such as saliva? And then what does the future hold? So with that, let me start with talking about diagnostics. And in many ways, it's the wrong name for our industry because diagnostics are so much more than diagnosis. Today, and our panel is really talking about the importance of the patient journey. So let me start with that patient journey and say it's not just about diagnosis. It's about 6 different pieces of that patient journey. It starts with screening, the average risk population. It then moves to early detection, typically those with high risk. Then it's focused on diagnosis, then prognosis, how serious is it? Therapy choice, and what's often overlooked, the importance of testing for treatment. Is the treatment working? So those are the 6 questions that patients ask. But what is the question we need to ask as an industry? And I'm going to be maybe controversial here to say, should we be known as the testing industry? And we are so much more than just diagnosis. That being said, I'm going to use testing going forward, but I'm going to give you the context and a little bit of the history. So we're going to start with the history of testing in diabetes. And this is something that hundreds, not even thousands of years ago, people were diagnosed with a disease called sugar disease or diagnosis. And how was that done? It was done by somebody tasting the urine, not chugging it, but tasting a small amount of it or even smelling it to say it smells and tastes like sugar. We then moved on to the contemporary, not so contemporary, 60 plus years ago, the urine test strip. And then for most of our lives, the blood glucose meter. And today, much more common is the continuous glucose meter or CGM. So that gives you a sense of diabetes over time. But why is that so important? Because I would argue diabetes shows a fundamental change in approach for diagnostics. The past was all about having one data point and making it as accurate as possible. Today, it's not just that one data point, it's multiple data points and making the trend as accurate as possible. But what does the future look like? In my mind, the future is continuous monitoring, the diagnostic data plus drugs plus AI. And what does that look like for diabetes? Something like the contact lens glucose meter. It's not just once a month, once a day, or 5 times a day. It's 500 times a minute. That's what the future is. Whether it's indeed a contact lens or something similar, I don't know, but it's continuous monitoring. And then it translates directly into delivery of the therapeutics. Where does AI come in? Well, often the data is not perfect from any type of diagnostics. And what AI can do is train on an individual person or their digital twin and add the data that's missing to make an accurate assessment of what type of insulin in this case or other drugs are necessary. So that's the change of approach, not about one data point, but about many, many, many data points. But where did this start? So I'm going to talk about the history of home testing and self-collection, part 1. And part 1, well, we'll forget about the 4th century and Hippocrates looking at urine, but really starts almost 70 years ago. And it's all about diabetes again. One of the first tests at home were urine dipsticks. We just saw a picture of them. They were looking at glucose. Then we had blood pressure monitors. And then a huge step forward was the pregnancy test through urine. Quite controversial, actually. We see the blood stick, the finger stick blood with those blood glucose monitors, the original ones, and a number of different tests, including cholesterol and strep A, that frankly did not take off and were only available for a short period of time. But the 1900s ended with oximeters getting at home. We know that were used a lot for COVID, but we'll get there. And then the FOBT and the FIT test with feces. So you see a number of different innovations in home testing and self-collection. But when did it really change? By the year 2000. Here is we already see dozens of different types of home testing and self-collection. It started with INR testing, never done at home. And then we know the revolution started by 23andMe with saliva or cheek swabs to do DTC genomics. And it continued with devices, whether they be Fitbit or Apple Watches, at-home HbA1c test, again, for glucose. And then you could see over this period of time how it has changed. When was saliva used? We talked about DTC genomics, then home HIV tests, and then we know it changed tremendously with COVID, when we had saliva or nasal swabs, and again, continuing with COVID for saliva or nasal swabs with combined flu A and B plus COVID. This has been a true revolution. When you look at this chart, the ones with a white background are fully home tests. You can get the data and the answer at home. The ones with a purple background are home collection. And then the collected sample is sent into a central lab of some sort to get an answer. So this has been a tremendous revolution, and saliva, and as you'll see, other samples are a core to it. But where did this really explode? You know what it is. It's in COVID. So let's look very quickly at the history of COVID testing. It starts out with symptomatic diagnosis and moves to active disease screening and surveillance. And much of surveillance now is happening with wastewater. Where were these tests being done? It starts in hospitals, central lab, point of care, and now home and point of need. But the important part is, where were we sampling? It started with lungs. It went to those NPS swabs, you remember, tickle the brain, then minimally invasive, just the front of the nose, and ultimately non-invasive. Yes, there was a moment there where we looked at, could breath be useful for COVID? And while it might be in the labs, it never really took off as sensitive and specific as it needs to be. But saliva played a critical role on a public health basis, as well as individual tests. And what's the cost? We always have to look at the money. It goes from thousands of dollars to hundreds of dollars to tens of dollars to just, on average, less than $5. And I think that the cost of a COVID test alone will continue to decrease over time. So that's the history. But where does this testing happen? For a long time, as we talked about, it was all in the central labs, and now doctors, outpatient clinic, and homes, it's in the point of need. So why is that so important? Well, I'm going to talk about my third area, is the fundamental shift in healthcare. And that shift is where the testing is being done and moving to the home and lower cost settings. And why is that happening? First, I'm going to talk about the explosion of chronic disease. So I look at those chronic diseases. Can I give you some data here? Well, first of all, the good news. The death rate from chronic disease just in the last 25 years has plummeted. It's gone down and down and down, and that is great news. But what's the challenge? The challenge is the healthcare costs for treating those diseases have gone up. And partly on an individual basis, it's gone up, but we're treating people happily, should be happy, for many, many more years than we ever did before. Heart disease, diabetes, neurological diseases are all of those that, while we can't always cure them, we can treat the symptoms much more effectively than we ever could. So that's the overall piece of the healthcare costs for chronic diseases. But what else is happening? Let's look at 4 other key drivers. Number one, decentralization of care into lower cost settings. There's lots of data here, but I'm just going to show you one chart that really, it's not only about costs, it's the fact that the total number of beds in the US is going down. You look at that chart and you look at the zero at the bottom and say it hasn't changed all that much. Well, about just over 1% a year. But what's the population that is most likely to go into that hospital? They're increasing at 3% a year. And we just talked about chronic diseases. While many of these people did not survive into an elderly state, they're now spending more and more time in the hospital being treated for these diseases. So there are fewer and fewer beds available. What's the next issue? Patient agency. And we're at a time that there's a lot of controversy in our country about how to handle healthcare. But I'm going to say that lots of people on every side of the political spectrum appreciate the importance of patient agency. And what do I mean by that? If you look at healthcare and ask people in a wide variety of settings, what do they want and how do they perceive their healthcare? Well, the number one area is they want to manage more of their own healthcare at home. And half of them say they can't get what they want when they need it. So it's all about control, and people want to take back control into their own lives. And what's the number one area of healthcare services that people are on average most comfortable with at home? What is it? Almost 60% want to have at-home test kits with instant results. They want to take control back. Interestingly, number two is also about being at home, and number three as well, telemedicine and virtual appointments, and number three is medication home delivery. So it's all about bringing these services at home. Third area, skilled labor. Well, that sounds good. Well, if we have lots of people, can we just treat them in hospitals? You just saw there are fewer beds in hospitals, and I'm going to say there are fewer people to help, whether it's in hospitals or doctors' offices. We can look at this in a number of different ways. One is kind of good news. Healthcare employment needs continue to grow. Number one, healthcare support, 15%. Number three, healthcare practitioners and technical people. But the gap between the openings and the hires just continues to explode. There are far more openings than there have been hires. Now, why is that? There are lots of reasons that we could debate, but what I'm confident of is that the US will face a shortage of people in every dimension here. And they will face a shortage, we will face a shortage of home health aides, of nursing, of lab technicians, and many of you in the lab industry very much know this is true. And it's not only in the US, it's true globally. The global health workforce shortage is critical now and only going to get worse by 2030, which is only 5 years away. So that's issue number three. And issue number four, and the one that it's both great news and bad news, but mostly great news. It's technology and business model advantages. What do I mean by that? Number one, treatments are getting better and easier and can be given at home. Number two, diagnostic technologies are better, simpler, faster, and cheaper, with little to no sacrifice in accuracy. That's what we need. And number three, what brings it all together? The digital connectivity that enables these integrated solutions. So let me share here. First, there's not a lot of discussion about this, but it is so important that healthcare is shifting to home. It started with hormone injections for in vitro fertilization and back to diabetes on insulin. So those existed, many, many years ago. But it was only since 2009 that so many chronic diseases, psoriasis, Crohn's, neutropenia, that's not so much a chronic disease, but happens with chemotherapy. GLP-1s, which they're popular now, but they actually existed as pens in 2015. So many of these chronic diseases, including migraine, one that means a lot to me, arthritis and otherwise, can now be given at home. And with more and more people comfortable with drugs at home, it's going to make it easier and more affordable and more reasonable to do testing at home. When I look at testing at home, I've talked about this a lot. I call it less invasive samples, but it's important to look at them in three categories, all with the letter E: established, emerging, and experimental. So on the top line, you'll see sample types that are well established from blood, eyes, in alphabetical order, and clearly saliva. But we see more and more tests being done on emerging areas like breath and gait and interstitial fluid, seminal fluid, menstrual blood. There was an approval you'll see later, and even, excuse my voice and scratchiness today, voice. And then really exciting, what is the experimental treatments we can do in the future? How can we learn from hair? How can we take a picture of nail beds to look for anemia? I think we will see many, many more exciting innovations in these less invasive and easier to use for consumers and also easier to use for physicians. Has the FDA recognized this? Well, 2024 was a banner year. I've talked a little bit about the flu, COVID home tests, the first menstrual blood home collection, the first over-the-counter glucose meter, so you don't even need to have diabetes to understand how your glucose changes, the first home syphilis test, and then additional tests that are all about the point of care, including even very recently, new blood tests for Alzheimer's. Most of them have been LDTs till recently, and in 2025, we had a new test approved as an IVD. So the FDA has really looked at the importance of this and granted many approvals for these new diagnostics in 2024. So where does that put us? So I'm going to have my last section here talk about a model for testing. And I'm going to start with what I call testing 1.0, 250 years ago. The question was, is there disease? 50 years ago, what disease? Today, what subtype of disease? Because it's very personalized. In the future, it's all about, can we identify risk? And indeed, testing 5.0 is, can we preempt disease? What are the tools that we're going to use? Testing 1.0 was just the doctor's five senses: nose, eyes, mouth, hands. 50 years ago, it was just manual testing systems. Today, it's virtually all automated. But what does the future look like? And we're really starting to be there today. It includes data analytics, and testing 5.0 is diagnostics, therapeutics, and AI. And when I talk about those data analytics, what do I include in there? As I just talked about, alternative samples, including saliva, and so many more. So testing 5.0 are those key questions, but I think what's most important is it's fully integrated with data, whether that be patient history or imaging or clinical trial or genomic data, or just the point of care test that we've talked about, whether at home or elsewhere. But the key is an integrated summary of all that data, not just in the doctor's brain, but I believe that we'll have the emergence of a data interpreter. And what does that data interpreter mean? Well, the real question is it a person? Is it a machine? By machine, is it software? Is it the physician or is it the patient themselves? We will see, but I believe that testing 5.0 will be here very soon. So as we look forward, what do I see? 2024, we've talked about what's in 2025 and beyond. First, I think we will see diagnostics get much more sophisticated in markets beyond oncology. We've all in the industry talked a lot about oncology as being the first place with personalized medicine. We will see it in CNS disease, as I've talked about earlier. It's already beginning in neurodegenerative disease, particularly Alzheimer's. We will see it in many more autoimmune diseases, which is a key area to use proteomics. And then lastly, I think we will see innovation in metabolic and cardiovascular, not just about GLP-1s, but focusing on MASH as well as the best use of GLP-1s. So that's on the market side, but now let's look at the technology. Three areas here. One is digital pathology. It's finally here. I've worked in this industry a long time. We've talked about it for years and years. It is finally here and it is past the tipping point. We will see dramatic increases in the use of digital pathology. Next, diagnostics for drugs, truly seeing companions used, monitoring for not just companion diagnostics, but true monitoring going forward. And it's not new to diagnostics, but AI will be used on the clinical, operational front, as well as test development. AI will be ubiquitous. So as I conclude, let me just say, I believe for the rest of this conference, we need to be talking about 5 key questions. Number 1, education. Who trains healthcare professionals on this next generation of testing? Number 2, education for consumers. Who gives consumers accurate information with so much misinformation out there and the risk of it? How does that happen? Number 3, it's always about follow the money. How will payers be reimbursed for testing? And will home testing be different from testing in the doctor's office or testing in a central lab? Who will invest in testing with these alternative samples? Research is core to our industry and is important to move forward. And then lastly, as I've talked about AI, how can AI improve testing? So I hope in the rest of our discussion today and for the rest of this conference, you keep these questions in mind so we have very clear answers as we gather again next year. So as I mentioned, Mara Aspinall, please feel free to be in touch or subscribe to the newsletter. It's free on Substack, and very much enjoyed the opportunity to work with you today, and hope we keep in touch. Thank you.